This is the OverReaction podcast.
Well, Mark, it's good to see you again.
Good to see you, Jeremy. Thanks for doing this.
Yeah, of course. You know, it's gee, how long have we known each other? What does it go
20
back to?
Almost exactly 20 years.
Yeah, I think it was
Oh,
yeah, I think it was 2000, 04. I was doing research at class, and I think you were you're at Cincinnati Children's, and I was researching like PACS or something like that. You guys had GE, or wasn't that it?
Yeah, that's basically it. As I recall, it was a busy time, and I don't remember precisely where we were in the cycles, but yes, I think that's right.
Yeah, we've been in touch, I think, off and on since then. So what have you been up to? What's going on?
Variety of things. Since we last checked in on what's going on clinically, a bunch of stuff. So I was in teleradiology for a while because I was initially, as you know, doing a lot of informatics research and development at Cincinnati Children's. Was interested in doing more of that independently and consulting in that area, and became a teleradiologist in part to support that work so that I'd have more independence to be able to do that. And then became a teleradiologist in a few national practices, growing in size, and then ultimately decided that I wanted to start my own practice. And that's what I've done recently. So in the last roughly a year, I've been focusing initially on finding another practice where I really, really wanted to work. And then because I couldn't find that, I decided I would need to start my own to try to build a practice that I thought didn't yet exist.
Gotcha. Well, maybe, let's jump back into kind of your story. You know, what your background, your upbringing, what got you into medicine initially, patient care, et cetera, and to get to the point where we are today.
Sure. So I would trace my medical aspirations back to about third grade. My grandpa was a physician, a general practitioner. He had trained before World War II as basically general practitioner, intending to go into practice somewhere in the US. He ended up volunteering for the Army and was overseas for World War II. He,
oh, wow.
Developed some surgical skills that he brought to his practice back home. And so he did a lot of different things. He would deliver babies, and he did ear, nose, throat. He did pediatrics, of course, adult general, internal medicine, appendectomies, and other surgeries. But he worked really long hours. He was working roughly 18 hours per day, and on average, he would deliver a baby every third night. So he's often in the hospital.
Wow.
So solo practice, doing everything, and very little vacation, no backup for call. So really kind of a physician who believed in patient care above all else. And that was the value, I think, that he brought to his practice. It's what his patients reflected to me when I talked to them. I'd visit his little town, and patients would stop him on the street to say hi and to introduce themselves to me. And that made a big impact on me. I thought that's got to be really, really satisfying for him. I know he loved it. I know that he often practiced not for the income, but because he felt it was a calling for him. And he valued it enough that he often would work without compensation. Sometimes this was a small farming community, and often people couldn't pay in cash. And so they'd ask, "What do you have?" And they'd say, "Well, I've got eggs. I have a load of firewood. I can do something for you to try to help you out, but I don't have cash." And he'd say, "That's fine." So I saw some of his invoices, and I saw one of them, for instance, was for delivering a child. He charged $5. I'm sure it was cash.
Well, I tell you, with inflation today, I'm sure you wish you could take payment in cows and eggs.
He was all compensated.
That kind of stuff.
Actually doing really well. But he loved it. And the thing is, the thing that was interesting about that also was that he became really frustrated with all the regulations and insurance requirements for payment, because it's not that he didn't charge anybody anything, but he was trying to help patients who had insurance to be reimbursed for their care. And he got really frustrated with all the paperwork involved. And at one point he said, this is getting to be so much that I'm spending more time on paperwork than I am on patient care. And I think I'm going to hang it up. I'm going to retire. And that was in 1978.
That's a shame.
Yeah, I mean, imagine what's changed since then, and how
Yeah, I was
much.
going to say, how would you think he would react if he was trying to practice medicine today?
I think he would be extraordinarily frustrated. And I can kind of hear how he would approach it today. And I think he would be really so frustrated. I'm not sure he would want to practice today. In fact, I'm pretty sure he would not want to practice today. But he loved his patients so much, it would put him in a real bind. And I think that that's kind of the moral conflict a lot of physicians are in today, where they went into medicine for the right reasons and they really value the patient relationship. They feel like they're trusted partners of the patient in a good relationship, and that they are there to try to help the patient get through some of the worst times in their lives and some of the most personal issues in their lives. And when that process and that breaks down because of restrictions of payer rules and regulations, pre-authorizations, in network, out of network, and ever increasing pressures to produce more cases per hour and generate RVUs, as is a common issue these days, it becomes more and more difficult to maintain those kinds of relationships. And I've seen it among many physician colleagues of mine today who have good relationships with their patients. Some of them have lasted for decades. And unfortunately, it's those physicians who now have to tell the patients, I'm sorry, but that drug is not on formulary. I know we worked for months, in some cases years, to find the right medication for you, but we have to switch. And the question is why? And the answer is, well, because it's no longer on formulary. So your insurance company won't pay for it. And it's enormously expensive. And many patients don't have a choice at that point. So they have to switch into a medication that's not as effective. They have worse side effects, and they don't understand why. And they kind of look to the physician to explain why, because this is the system that the physician works in every day. And it's very hard for the physician to explain that. And I totally sympathize with the physician, because the physician certainly didn't make that decision, but they have to be the bearer of that bad news. And they have to help the patient, who's their friend and their client, to navigate this really, in some ways, it's an impossible system. And so sometimes there are no good options, and it's through no one's fault, but the physician feels responsible because they're the mouthpiece and the face that the patient associates with the healthcare system. That's really hard on both. It's hard on the patient, it's hard on the physician. And I think that both sides of that equation end up feeling helpless and frustrated and responsible in some way. I guess I can't really say the patient would feel responsible, but the physician certainly does. And the patient certainly feels frustrated. And I think what's common to them is they both feel in some ways that trust has been violated, because they can no longer work as collaboratively as they had in the past. And it's not clear where the fault lies, but they just know it's not working as well as it used to. And I think that that is a cause of physician burnout.
Yeah. I mean, you've seen probably some of my riffs I do on like social media or LinkedIn. I'm always, I don't mean to necessarily pick fights, but it's just this, the way the industry is going is that, you're describing your grandfather, right? When, like, I take it, he inspired you to get into patient care, into the practice of medicine. And
Yes.
where he was so close and so aligned. But then the industry itself, all these things, this bureaucracy and all these intermediaries and et cetera, have caused it almost, I mean, it's not just a separation anymore because of all that friction in between. It's a lot of it's unnecessary. It's almost, in some cases, I see it being adversarial.
Yes.
And it's not either, it's not the clinicians, the physician's fault, and it's not the patient's fault. It's the system that has caused this divide to happen. And the further you get away from someone and the less you understand them, it's easy to have animosity creep in. Because when you really understand somebody, it's hard to, unless you're just a really bad person, it's hard to hate that person, right? So you have this pulling apart where it's increasingly difficult for physicians to spend the time because they're documenting in horrible EHR systems, and they're spending a lot of time in that, and so they have that burden. They have other administrative burden in meetings and every other sorts of things. So they're just literally limited the amount of time they can spend with the patient. and the patient can feel it. And the patient feels like a cog, right? Because they don't feel like they have any control in the process at all, at any level. It's everything's scheduled around not the patient, around every other thing in that. And then they get put in a waiting room and it's always longer than they said. And then if they're going to get results, it's always longer and it's opaque pricing. They don't really know what's going on. And then to get results is complicated. And if they move to a new physician or whatever, the data isn't flowing. And it's not the physician practice or the hospital's problem necessarily. It's all this stuff. And so, and I just don't, it's hard to see how it gets really better. Maybe that's why you're doing what you're doing now.
It is. I think what we lose, I mean, I generally agree with the description you're giving. And the thing is that in none of that description did I hear, where is the common enemy here? It should not be the payer. It should not be the system. It really should be the disease.
Yeah.
Right? How
sure.
can we not count the 800-pound gorilla in the corner, which is the disease? It's the reason the patient has come to the physician. It's either to avoid disease or have disease diagnosed and treated. And somehow any animosity now is toward the fact that there was a 7-month waiting period before the patient could schedule an appointment to see that physician. There was a wait in the waiting room. There was a wait in the room to be seen. And then there's time pressure when the physician does come into the room that may be unspoken, but both feel it. And they both know they don't really have time to get through a full history, and maybe as much as either the patient or physician or both would like. The physician may not have access to all of the records that are relevant. They don't necessarily have access to all the diagnostic tests, at least the primary source data from the diagnostic testing that was done, particularly if that was done at another institution. And so the physician in the back of their minds may know that they have incomplete information they're working with, but they have X number of minutes to make a decision, make a recommendation, explain it to the patient, answer the patient's questions, and get to the next room so that at the end of the day, they don't have people who have been waiting an hour and a half and are frustrated. And I think there's increasing pressure now to do that more and more quickly, to see these patients more and more quickly. Yet there's more and more information available. The more technologically advanced medicine becomes, the more data there are that we could use if we only had access and time to make full use of it. And I think that tension is something that makes it frustrating even more for both the physician and the patient. But you're right. This is a major thrust for the idea of starting a new practice for me. And I didn't really get through my training history or any of that background, but my background is that in basic form, I'm a very subspecialized physician. I did 3 fellowships after residency. Each of them lasted a year. And so I'm a subspecialist in pediatric neuroradiology. And I did fellowships after residency, after a general radiology residency, in neuroradiology, which was actually an MRI fellowship with an emphasis on diagnostic neuroradiology, and also pediatric radiology, and also pediatric neuroradiology. And all that training focuses on imaging of the brain and spinal cord in patients from birth up through roughly 18 to early 20s years of age. But most patients don't know there are people out there like me. And frankly, there are not many people out there like me. I'm very, very subspecialized. But if a patient has a child, I'll put it this way, if a parent has a child and that child has a new diagnosis, such as a brain tumor or a lesion that's discovered, for instance, after a fall on the playground, that might be a brain tumor, patients and their parents don't often have access to somebody with super subspecialized training. So it's a radiologist interpreting the case who often is not fellowship trained in either pediatric radiology or in neuroradiology, and almost never in pediatric neuroradiology because there are just a handful of us. And as a result, parents don't know that they maybe should get another opinion if there is anything found, or even if there's nothing found, because there might be something on the imaging that wasn't caught. because the radiologist who interpreted the exam didn't have super subspecialty training and experience. But most parents don't know that there is any of this sort of nuance within medicine. It's kind of like the Wizard of Oz. Who's behind the curtain? Well, if they have an MD after their name, many parents and many patients think that that means that they must be completely qualified to read every radiology exam, if they're a radiologist, for instance. And that's maybe technically true, but there's a difference. If you have, for instance, a pilot approaching the gate at the airport and you overhear them whispering, now, what was this? Was this a 737 or 747 about to fly? A lot of work on 737, but not 740. If you hear that and you're in the boarding area, are you going to get on the plane? I mean, they're a pilot. They obviously have thousands of flight hours. But if it's a plane that they haven't flown frequently or have been subspecialty trained on, pilot may not be just everything you need in order to get through that storm safely or to make it to that destination if something goes unexpectedly wrong during the flight. So there are nuances that I think most patients are unaware of. And it's true throughout medicine. It's not just in radiology. Many specialties have subspecialist qualifications that you can undertake educationally as an option. And a lot of physicians do that, but many physicians don't. So I wanted to make people like me who are subspecialty trained available to parents who have questions, patients who have questions, physicians who are already engaged with those patients and parents who have questions. Because right now it's very difficult for parents and physicians to reach subspecialists. And by physicians in that context, I mean primary care docs or their pediatricians, et cetera. And that's true throughout medicine. Specialists who refer cases to, for instance, radiology, often have difficulty reaching the radiologist if they have a question once that study has been interpreted. They pick up the phone, they try to reach a radiologist and they can't. And they try to reach the specific radiologist who read that exam. Very, very difficult. And if you're a parent or a patient and trying to reach the radiologist to get some additional information or explanation, it's almost impossible. In fact, it's effectively, I would say, impossible to do it. The system's just not set up for that. Everybody's too busy, and the specialists tend to be siloed and tend to be hidden behind firewalls in hospitals so that effectively they can get their work done without being interrupted. And that operationally makes a lot of sense. But if you're that parent, you just want to know the truth, and you want to know, what did they really think when they dictated the exam? Was there a question that they had that maybe a different specialist who has more training in that area would be a better person to ask? Did they have time to ask such a person? If not, could the parent take the case to somebody else and have a subspecialist have another look? Not to try to get somebody in trouble, but just because this parent wants to do the right thing for their child. It's the most natural thing I think any parent would want. It's just the truth. So it's been really interesting. Since we launched, I'm getting patient requests, which are often, quote, "I need help," unquote. I just want the truth. Or I'm having pain because of a trauma that I suffered. I have a history of back pain and a history of surgery, but it got worse after the fall. I don't really trust the opinion I've been given. A surgeon suggesting an operation. I want to know if that's wise. I don't want to live my life with this kind of pain forever, but I don't know what to do. And I just want somebody I can trust to give me an unbiased opinion. Is the surgeon going to suggest surgery because they want to do another operation and bill for it? Or is it really in my best interest? Those are the kinds of questions we're getting from patients. They're very, I think, earnest questions, and they're extremely reasonable. But right now, the system's really not set up to allow a patient to take a long time, I guess long would be in quotes there, to take enough time in the patient's mind to answer their questions and make a thorough decision about patient care. I had a woman who, when I explained what we were doing in this practice, said that she'd been given a new diagnosis of breast cancer and that she had an upcoming appointment months later, and she was going to be given 10 minutes to receive the results of a biopsy and make a decision on the spot whether she wanted a double mastectomy.
10 minutes?
Yeah. Yeah. And this was months. So where's the information she would really benefit from now so she could have some more background? And why would there be that kind of pressure? Why wouldn't there be a longer appointment and follow-up appointments available so that she can think through this? Because it's not a reversible decision. So those are some examples of cases that, you know, I didn't go through my background really thoroughly, but my background is to be a subspecialist where if somebody has a question in my area of subspecialty, I know they would benefit from talking to me about it. I could give them an honest opinion without bias about what I think is really going on. They could weigh that with their surgeon, with their primary care physician, whomever it is. And then they'd feel better about the decision that they make. And even if the decision is one between two bad choices, at least they have more confidence that they've done what they can to get the right information, or at least the best information they can to make as good a decision as they can for their personal situation. And in talking to a lot of people about our practice, I don't get the sense that many patients at all feel as though our current system supports that kind of a decision-making process.
Yeah, there's no way. It doesn't at all. And to give people peace of mind, to give them more information, to give someone who can take more time to answer questions because they're not so insanely rushed, to get to the next, to get to the next, to get to the next. So you opened your virtual doors at MD for Patients 3 months ago, 2 months ago? About how long?
Since how you define open the virtual doors, really a month ago.
Okay. And do you see over time more patients coming direct, or do you see your organization being, getting more patients that are coming from super overworked pediatricians or family medicine doctors or primary care physicians, where they might be rural, they might even be urban, and they're just inundated? Or do you see, I mean, I guess it's kind of hard to tell initially, but I mean, which do you see emerging over time being more of where the patient flow would come from?
I'm not seeing a pattern at this point, not yet. I'm seeing a wide variety from geographic regions in terms of the types of questions that were being asked. And I'm not sensing that there's any theme in terms of anger or distrust. I'm seeing people who have, for instance, I had a patient ask me about a missed tumor that this patient discovered on their own after they got home and popped the DVD from the radiology department into their own laptop. And this is somebody in a technological industry with zero medical training. And he was shocked when he got the phone call that evening that everything was normal. He then immediately lost trust, and he was looking for truth.
Yeah.
But it was a screening test. It was supposed to be normal, right? And so it's not that he's deep into a diagnosis and questioning it. It's that this was something that he recognized as being wrong and didn't know where to turn next. And by the way, that was proven to be a cancer, and he had to have surgery for it. So there's no question that he was correct.
Yeah.
And the original reading was incorrect. And then we're getting also patients, as I mentioned, that the hypothetical I just gave you with a patient with back pain after a trauma who had a history of surgery and was getting conflicting advice and just wanted to know what's the best path forward. That's a true story, and it has to do with somebody who had been in the system for years and years and years, and who was an informed consumer. So it's not just patients who have no medical background. And it's not just sophisticated patients who know some of the nuances of different specialties and when should you be concerned if surgery is recommended. It's everybody. And the fact is, everybody's a patient. Everybody on the planet at some point is a patient.
Yeah.
And so none of us are immune to being in that position. I think very few of us enjoy being in that position. It's a very vulnerable position. And it's a very personal thing. I think there are very few things out there. In fact, I would argue there are none that are more personal than healthcare and healthcare decisions, or more precious to people. It doesn't matter how much money you have, how much power you have. If you're struck with a disease that is really debilitating, that's at some points insurmountable, regardless of how much power, prestige, money you have. And so it's a great equalizer, healthcare and disease. So I think that given how frustrating it is for patients to be in the position that we're putting them in these days, and by we, I mean, not we, the physicians, but we, a healthcare system, it's becoming a much, much more common issue. And I don't think anybody has a good answer. So I think it's something that we really need to start discussing.
Yeah, I wish you guys would have been around a few years ago. I do a lot of mountain biking, and some jackwagon equestrian rider, I guess, hated mountain bikers sharing the trail with her. Even though we built the trail, she used it, but we built the trail. A lot of people don't realize that mountain bikers build most of the trails, a lot of the trails, then maintain it. So anyway, she had strung around a blind corner. She'd gotten off her horse and put a log across the track. So I came flying. At that point, I got limited options. I could try to ride it out, which I'd just break my bike and die, or I'd just jump off the bike. And I did. And when I landed, my shin hit on a rock, my left shin. And it was serious enough I couldn't walk on it. Like, I'd had enough injuries to know like something's wrong. And it swelled up pretty significant. I figured, it's probably just a hematoma. But it was so hard. I'm like, I think I've actually done damage to the bone. So I kind of, get on my bike and limp down and go to an ER. And they do a scan. And I was next to the radiologist. I don't know how they did it, but I ended up being next to the radiologist that pulled it up. And he's like, holy cow, that's a massive fracture. And I'm looking at it, and according to him, is the dark line that went down in front of my shin and went around. And he's like, we got to get you in for surgery. And I just remember, but I'm like, hang on a second. I would be feeling pain up by the knee and by the ankle if that's the case. And it wasn't. It was a vessel, right? So I just remember going, do you mind like send it to an ortho or something? Like, just I'm not doubting you, doc, but I'm just, I don't know. Because I've been at RCNA enough times, and I've seen enough scans to go, boy, that looks too smooth. Yeah. So it gets it, and I heard on the phone, they're like, what are you talking about? And I can't remember the name of the vessel. It's like, no, it's the something vessel. Like, it's not a fracture. Like, he just has a big hematoma. Give him crutches, get him out. And I'm like, well, whatever. Yeah, well, so that was one of those things where it was a new radiologist. He was barely out of his residency. He had no specialty in obviously anything dealing with, lower extremity or bone or whatever it might be. Again, I'm not a specialist. So to your case, I've had multiple incidents where it's, I'm not a doctor, can't diagnose myself, but something isn't connecting in your brain. Like, that's something, this is just different than what I'm experiencing or what I'm thinking. So.
Yeah, and you just mentioned a couple of things. You mentioned degree of training, length of training, and length of practice beyond training, and lack of specific training in that area.
Yeah.
Yeah. And so we are invitation only. We're extending invitations to physicians to join us who are very experienced, generally 20 to 30 years of clinical experience. And
awesome.
with excellent training and expertise in the areas where they're rendering consultations. So I think it's really important to keep physicians in their sweet spot. Physicians may cover all areas of radiology, for instance, but not be as comfortable in some as others. And I think it's a mistake to pressure or force them, particularly if they're doing a consultation, to try to determine what's really the truth here outside of their area of greatest expertise and comfort. And so one of the things that we do is we do not pressure any consultant to take any consultation case that they're not completely comfortable with and that's not really well aligned with their skill set and experience. And I think that that's another problem with the pressures that we're all under these days in terms of payer models and in terms of workload, because busy practices generally don't triage cases to the most qualified radiologists. And I'm speaking just about radiology because it's the field that I know best. But they instead will triage them to whoever's available to read the next case. It's a very common practice. And so there may be somebody who does a lot of chest and very little brain, who unfortunately is the next person to pick up that brain MR that shows something subtle that a neuroradiologist would recognize, but that a chest radiologist with no fellowship training would not. And now you're looking at the difference between a misdiagnosis and a correct one. And the penalty for having done it correctly would have been proper triage. And as you know, we didn't talk about my background, but one of the things I did was working on software systems to improve triage so that it was more appropriate, more timely, and improve patient satisfaction and physician satisfaction. So you've identified, just through going through the system as a patient, a problem that could be addressed, but because, again, of financial pressures and productivity pressures, is often not addressed, and that directly affects patient care. If you hadn't been as sophisticated a consumer as you are, hopefully the orthopod, before sharpening their knife and opening, I'm not suggesting that surgery would have been indicated. What I'm saying is that often misdiagnoses that originate are not stopped. They're not corrected. Once that train leaves the station, it gets propagated in the chart and it becomes considered truth. And interestingly, even after it's been corrected by further testing, the prior notes that make that diagnosis seem like it's truth aren't corrected in the record. They stay that way. And some facilities, if a patient switches facility and they have outdated records or no access to the new updates, may continue to operate on the presumption that that diagnosis is wrong. And that's another kind of situation where we can help to look at records that are scattered and try to put together the full story, try to correct the picture and generate a report and record that can then correct future care and make it go in the right direction. Because misdiagnosis happens. It's unfortunate, but it happens. It happens with frightening frequency. And I don't think we'll ever get to 100% accuracy the first go around, but I do think that we have a need to reconsider the data that we already have before we go too far down incorrect pathways. And I don't think there's a good fail-safe system in place right now to catch those. And putting it on the patient's shoulders, like it was in your case, is really not a good idea for a whole bunch of reasons. Primarily that patients don't have any way to question or know when to question a result. But there's also, I think, tension in patients if they consider asking for a second opinion, like you. That story was great that you just gave, because you didn't want to make the physician feel as though you were questioning them. So I put it back on you in a second. I'll just say, I'm imagining you didn't want to offend them because there's some degree of respect for the physician as a patient that most patients do have, and they don't want to hurt feelings. But you interact so frequently with physicians that you are probably less concerned about stepping on toes than some patients might have been, and frankly, more concerned that you were right, which you were. So you were willing to question, and you were willing to ask for that second opinion and that consultation. And that's what got the story corrected. But for a lot of patients, they don't want to do that. They are afraid of offending their physician. And it's interesting, the commercial air industry learned long ago that it's important for every flight crew member to be empowered to question the pilot because of this disastrous air disaster. It was a monstrous crash between two jumbo jets. And it occurred because co-pilot was afraid to question the pilot who was pulling onto an active runway in front of another jet that I believe was in the process of taking off, if I recall the details.
I think you're right.
Yeah, and that co-pilot knew there was a problem, but did not feel empowered to call it out. And as a result of that culture in which authority was not questioned ever, a lot of people died. And that's what changed. That's what started the change in the commercial airline industry toward more checklists and more empowerment of everybody to be able to question decisions that were being made by outranking members of the flight crew. And it's part of why in the OR now there are hold points when everybody stops and makes sure that everybody's on the same page and the correct site is going to be operated, et cetera. So that happens in an OR, but there's no patient who's awake who can step in. And it's a very controlled environment. We still, I think, have not gotten to the point where patients feel that they are empowered with real information and data to be able to question physicians in a non-threatening way. And I think physicians are hesitant to accept questioning and criticism from patients, in part because of insecurity or because they may not be sure the patient has a rational basis for questioning them. They may just think that they're being questioned, their judgment's being questioned for no good reason. So that's another role we can play. We can help empower patients by reviewing a case carefully, taking into consideration as much history as possible and prior exams, et cetera, and likely have a broader picture with more data points than the original treating physician did, and then give the patient something to take to that physician that will not punish the original physician, but just help to inform them there's more data than you were aware of that will affect your decision, and here it is. I think those are difficult decisions for patients to make if they don't have somebody in their corner. Some patients sue if that's the case, but we don't want to get to that point. We really, as a system, will save tremendous money and a lot of morbidity for patients, a lot of pain, and intervene in diseases much sooner if we don't have a system that requires a patient to sue in order for everybody to take a step back and look carefully at the records and figure out what's really going on. We need systems so that patients can question in a non-threatening way, and so that physicians who are very experienced and have subspecialty training that is relevant to the case at hand can take the time to get the right answer as best we can, and then take a deep breath and figure out where to go from there forward. Nobody needs to be sued. Nobody needs to be embarrassed. And in fact, hopefully everybody learns from the experience so that the next time the same situation comes around, that next patient who has that situation benefits from that experience. That's what I consider continuing medical education. Learning as we go from people with expertise who can help us. So one of my goals for MD for Patients is not to be threatening, but instead to be considered an adjunct, a member of the team who can extend the expertise of the existing local care team for the benefit of the patient. Because at the end of the day, we're all about patient care quality. And I know that's an overused, it's an overused expression, but the fact is that's what it's all about. It really is all about doing what's best for the patient. And if you actually live that mantra, then the answer to what to do in a lot of these situations becomes really clear. And it's usually take a deep breath, look at the available records, try to look with an unbiased eye, make your best decision that you would make if this patient were your nephew, and then convey that transparently and honestly to the patient and their existing care team so that it has the best chance of making a positive impact in that patient's life as possible.
I mean, yeah, for me, in working with, my primary care physician, them having a service, a team of experts, so to speak, that can help them and advise them, and they can talk to me if I need to. I mean, that would keep me. So you think about patient churn and customer churn, that would keep me really loyal. I mean, I have another story. I just have so many accidents on my bike, man. I have lots of stories just because it's, unlike other people that have disease thrust upon them, I'm bringing it to myself. I'm courting.
That's self-referral. I think there are rules about self-referral there, buddy.
Oh gosh, yeah, no doubt. So I had like one of my worst accidents ever, and I'd broken 3 or 4 ribs in the front and 5 in the back, and like half of them were fully displaced, and my lung had collapsed, and as I tore some stuff in my rotator cuff, and then my shoulder blade, I broke it in 3 spots. My bike was actually okay. I only had to replace part of the handlebar, which is the most important thing. Even as I was dragging it down the mountain like I was Sylvester Stallone beat up in a movie, like, hey, Adrian, I was dragging my bike down. The bike was okay. Anyway, so I went to the trauma ward, Park City Medical Center. Great, awesome, love them. ejectomy would die. They found all the issues. So then they send me to my primary care physician, and I love her. Lady's trained at Harvard, but she doesn't try to pump me full of drugs. She listens, really consultative, really holistic approach to people's health and medicine. But she has another physician that works with, and she's like, okay, come back in a couple of days. We need to assess your, what's going on. And I don't know if he didn't look at the chart or what, but he grabs my arm and starts bending it backwards. And I'm like, I grabbed the guy's arm. I'm like, he might have thought I was salt. I'm like, check the chart. Because it's my shoulder, it felt like it was gravel now. And he looks,
I don't mean
like,
to laugh.
I was like, he's like, oh, and I'm like, my shoulder blade's like gravel. Don't, I know you have to worry about locks. Like, oh, okay, yeah. And so I went to her and I just said, I can't come back. Like that is like a no-brainer kind of thing. And so it was interesting. She was fantastic. And if it was her, she would check the chart. And if she didn't know what to do, she goes to her, and looks in Up to Date or Walter's Clear, whatever it is. And she'd always reference, always the way she is. She's fantastic. Or if she had y'all, that's what she would have done. So that's one of those things where I'm like, not necessarily an advocate necessarily, but it's providing that expertise, that really specific expertise to those care providers before they do something like that, right? Like if I was that doctor, I'd say, hang on a second. Have I seen this kind of patient before? I'm check the chart. I haven't dealt with that I haven't seen someone come in with all that stuff going on, right? Like, oh, if they had MD patients, they could have someone like you or someone who's I guess you should ask how many different subspecialists you have now. Like what the breadth of services that you have.
Right. We are covering all services. We're still in growth. Yeah. To be clear, we're in growth mode, but all specialties and subspecialties are fair game. And one of the things I was going to mention is that you mentioned the primary care physician and their resources. One of our goals is to help primary care physicians by offering access to specialists and subspecialists much more quickly than they otherwise can get it. And that's a benefit to them.
Awesome.
Right. So if you get referred to a rheumatologist, you may have a 6 or 7 month wait time. And I'm just throwing out numbers that I've heard from others. I'm not purporting to know precise numbers, but it's often many weeks to months to get to the next appointment with any given specialist. Well, now let's say that instead of a single issue, you've got an issue that needs to be seen by 3 or 4 different specialists. You have a complex disease process that requires a cardiologist, a pulmonologist, a neurologist, a GI surgeon, for instance. Now you're going to have to wait for every one of those specialty appointments to open up, and a note will be generated by each of those specialists. It is unlikely that those specialists will call your primary care physician, who may be extraordinarily thorough, but does not have a chance to ask all of their questions directly necessarily. And even more importantly, every one of those specialists is unlikely to contact any one of the other specialists who are rendering decisions and opinions about your case. And unfortunately, the information that any one of those specialists gives to the others might affect their opinions as well. So we silo. The way that our system now works, we often silo specialists such that it's very difficult for them to have an interdisciplinary approach and collaborative discussion about a case where everybody's very familiar with the case. A counterexample of that sort of would be an interdisciplinary or multidisciplinary conference. Some hospitals do those, and they're often isolated to specific disease processes. They may bring in a few different groups of specialists, but often the way they work is one physician who knows the case well will present it, and the other specialists don't know the case well, but they just chime in based on their experience or a literature reference, et cetera. But they don't really have skin in the game. They're coming by maybe for the collegiality, to learn a little something, and maybe to get lunch. There may be lunch provided at some of these to attract people. And so you tend to get kind of off the cuff opinions as opposed to, I know this case. I went through this as though this were my patient. I took the time to go through all the records relevant to my opinions. Here are my opinions. What are your opinions? Oh, that's interesting. I didn't pick up on that. If that's your opinion about that organ system, that affects my opinion about this organ system. And you add a third and a fourth element to that. And pretty soon, if you have a group of experts who are very comfortable with each other and trust each other and each know the case really well, you've just added a tremendous amount of value to that diagnosis that no primary physician, no matter how thorough or how good they are, can possibly broker. Because instead of that model, what typically happens is primary care physicians receive siloed bits of information from different specialists, and they have to put it all together. And they have to ask themselves, well, if the pulmonologist knew this about the heart, would that have affected what the pulmonologist recommended? Maybe I should call them. I can't call them. I got to see 30 more patients today. So I think it's a great point that you make about primary care physicians and helping them. And that's something I really wanted to emphasize. We're there to help existing care teams. We are not there to steal patients. We're not there to make people look bad. Our goal is to improve patient care. Again, just come back to the prime focus, which is patient care. And obviously, the best thing for the patient is to collaborate among subspecialists and make that information available to the patient and their care providers locally.
Awesome. So I want to make sure we get a couple questions done before we run out of time. So from a primary care physician, how do they start engaging with you to have access to your consultants? Like, what is that process like to start to reach out to you, to engage with you, and then how do they work with you, or how do you work with them? Like, what's kind of the process? And the other side, answer the same question for the patients, from the patient side.
Sure, I'll start with last question first. The way a patient would engage with us is they go to our website, which is mdforpatients.com. It's all one word.
And we'll put a link in the description. So I'll put a link to your organization and then to like your LinkedIn profile and anything else you want. So we'll add that in the description of the podcast.
Thank you. That includes intake information for a patient to populate. And once the patient populates that information, we then will get in touch with the patient and begin the consultation. So it's a pretty straightforward process for an individual patient or a guardian. So if it's a minor child or if it's a parent who is incapable of making their own healthcare decisions, a durable power of attorney person could enter the information on their behalf and sign the forms for intake on their behalf. So that's a pretty straightforward process. If it's a physician who wants to engage our services for a specific patient, they can call the number on the website, which we could also post if you'd like. And that phone call will get them to a person who can understand the situation from the referring physician side and then figure out the best way to get the patient onboarded. Generally, it's going to mean putting the patient's information in through our standard intake process where the patient would enter the information themselves. But there's no reason that a physician can't contact us directly and we can do an inpatient, or I'm sorry, we can do a patient intake manually that way.
Gotcha.
I'll also say that we are more than happy to establish ongoing relationships with primary care practices who have multiple patients and they think that they would want to use our services more than once. It's a really straightforward thing for us to discuss with them a relationship that would prevent them having to go through any kind of complex process every time they have a question for a given patient. So in those cases, I would recommend that they, again, call the number on our website and ask to contact me directly, or we can ask our chief medical officer, for instance, to get in touch with them to explore exactly what their medical needs are, and then we can work out how to proceed from there.
Gotcha. So do you see, or where do you see specific areas, disease states, or cases that are particularly acutely underserved right now?
Can you ask the easier question, which is what's not being?
Sure, you can take the other side of it. I'm okay.
What's really well served?
We can take the other side of the binary.
Where is there no need? But, honestly, Jeremy, I don't know that I have the data to answer that question as accurately as I'd like to be able to. But I can say that
Anecdotally is fine, or
well,
just intuition. I'm not going to hold you to it. There's no exam at the end of this.
sure. What we're seeing right now is a lot of radiology related referrals. And frankly, the reason for that is in a way historic. When I started the website build, I thought that there was a chance that I was just going to be a practice of one, because I wasn't sure how many colleagues would really want to do this kind of subspecialist direct patient care model, how many would want to participate in that. And so it was a fairly heavily weighted toward radiology and specifically pediatric neuroradiology toned website. And it was only after we developed, we being the team that was helping me develop this website, we developed a landing page so that if I called some friends of mine from med school and asked if they might be interested in joining, they would have someplace to go to confirm that I, in fact, wasn't off the deep end and we really did have something going on.
You were legit. Yeah.
Yeah. So we did that. We had the landing page. I made a few phone calls. My friends sounded very interested. And then I thought, I was calling people who I thought really valued patient care. Again, I was looking for the character of the physician, not the specialty. The people I felt would really understand the importance of patient care quality, transparency, trustworthiness, treating patients with dignity and good communication. Those are the people I called, and it turned out to be multiple specialties, and they were interested regardless of whether they were in radiology or not. So quick pivot, we had to change the website's focus and make it clear that we're really covering all specialties, but didn't have enough time to rebuild the website. I didn't want to delay launch because of that. So that's kind of the backstory. And I think that's why we're getting a lot of radiology requests relative to others. But I also think radiology is one of those fields where, like this example I gave you, you can come home from the department of radiology with your DVD. And just like you gave me that example, you can see the image right there, right? I don't think that a lot of people read, there's some diagnostic tests that I think are difficult for people to read, that are very heavy on numbers or lab data, et cetera. But in radiology, it's image-based. And in the case of that patient who saw their own tumor, they were looking for symmetry, asymmetry, masses, smooth contours of organs, the kinds of things that we look for as radiologists. They picked up a tumor and now they don't trust. And I guess the question would be, back to you, Jeremy, what fields in medicine do you think we're not recognizing errors and patients are less likely to know there may be a problem because they're less visual than radiology? And what do we do about that? What are the objective metrics that patients can use to know whether the person who interpreted their EKG or whatever it is as a diagnostic test or an overall diagnosis, did they maybe miss something? Did they have the subspecialty training that would have been ideal to interpret that exam or to make that diagnosis? So it becomes an interesting question. And don't know the answer yet, but it's going to be interesting to look for patterns in the data as we progress and as we grow.
Yeah, I think maybe we should talk later in the year again, because it would be really interesting rather than supposition and anecdotes right now, which is good. You're much more careful than me. It must be your training. I tend to just just start swinging haymakers left and right, and we'll see what happens.
I've never broken 3 anterior and 5 posterior ribs at one time.
Dude, I'm an idiot, man, when it comes to that. Like it's just, you'd think someone in their 50s, like, because I'm in my 50s now, would that would be I might need a scan to figure out like what's wrong. Like there's some part of my brain that just doesn't have beer that kicks in. Like it's the same thing. I just did rappelling, and we took this part of my church. I mentored young men specifically, although sometimes young women, you have to be so much more careful now. You have to have like 17 adults at all times just to make sure, everybody's story's straight. And so we take a lot of young men down, and I love rappelling. So I love going in these really narrow slot canyons we have all over southern Utah, because it kind of scares the boys. And a lot of them are punks and they're cocky and they just rebellious. You get them when now they're having to go down a cliff backwards, 100-foot cliff or 60-foot cliff with an overhang. All that punkiness and being a jerk, it goes out the window, 100% out the window. But normally the places we go, we have really good anchors where someone has drilled, like 8 inches or 10 inches into the side of the rock wall, the canyon wall and they'll put an anchor that way, and then they glue it. And so your anchor's right there. But some of these we go to, it's just webbing, which is kind of this cord that's around a boulder. And sometimes a boulder doesn't look that big, although boulders are, if it looks small, it's still probably 300-400 pounds. You just don't want to jerk while you're going down. And so some of these, one I went down and I forgot to check the webbing to make sure that it was, there wasn't any cuts in it, etc. And halfway down, I'm like, that was pretty stupid. That's pretty stupid. Like everything relies on. So I get down, and I have these two-way radios right here, and I have one at the bottom, and the other guy's at the top, so they can hear. And I'm just like, hey Thomas, can you go check that webbing before you send one of the kids down? Go check the webbing once. So I just have something in my head that just doesn't click to go, hey, why don't you preserve yourself? Right. So it's so I'm, it'll be interesting to talk to you in a bit to see where those areas kind of coalesce, because I talk to so many people, so many people all the time. That's my job, is I'm always talking. So there's so many bad experience stories where someone goes in and they've got an autoimmune disease and their doctor doesn't believe them. Right. And this person's like, I'm not just coming in complaining. I eat certain things and it does this. Well, no, we did a quick test on you. You're not allergic to that. And the person just goes, yeah, but it happens so often and I've eliminated everything else. I really think I have a problem with this. And then they finally get to a doctor who goes, well, you have a problem with this. And they're like, for 3 years I've been, and then they don't want to trust. They're all like Nick Fury from Marvel, like, and this is why I have trust issues, right? So to answer to your question, because you got to pose it, I think in some ways rhetorically to me, I don't know, because I've seen it when it comes to radiology, and I've seen it with lab values. I have a dear friend, young lady, who she had a stroke, and she's like 23 years old. Well, 23-year-old healthy people don't have strokes. Like, that's not like a normal thing. And so she'd done her own research, talked to her mom, and they're pretty sure it was, and I don't want to say too much, and she ended up being right, but she got sent to not a neuroradiologist, neurologist and some others, and they're like, no, we think it's from whiplash or something from several years ago. And she's like, why would it take 3 years to show up? Like, I don't get it. And so that ends up being what she thought it was, because she did huge amounts of research. And one thing, there's a lot of information out there, and a lot of it was garbage, but she's a pretty smart person. That's what happens when you have people that are really smart. And like you said, they have access to a lot of information, and they start looking for things, in this case, and they read about a patient or they read about a doctor saying something, and they go, well, I haven't seen anything else. And so having access, my grandpa used to say all the time, you want to tell time with 2 or 3 watches, back before you had atomic, connect to that atomic clock in Colorado. And so that's really what I think, what's so great about what you're doing is you have absolute experts who have gone through the experience of making mistakes and learning from mistakes, et cetera. They're not a new person who's super smart but doesn't have experience, because super smart people who don't have a lot of experience, they can be a little, I don't say dangerous, I don't want to make it sound that way, but there's just no substitute for the experience that you're specialists and that you can bring. And to have someone who's overworked and doesn't have access to information, hasn't gone to all those different fellowships like you're talking about, that can leverage all parallel process with all the brain power that you can bring. I mean, that as a patient would give me a lot of confidence.
Yeah, I think you're right. And I'll give you kind of a parallel. This is not a new concept that patients often know a lot about what's going on with themselves. I remember back in med school, one of my favorite professors said, do you want to know what's wrong with the patient? And I said, yeah. And they said, ask the patient. And you know how easy it is to forget that with all the technical tools. And
yeah.
And
wow.
You also raised another point. You raised the point that the internet's now available, and that allows patients great access to wonderful information. It also allows them to scare themselves to death, because almost any condition, any symptom, you can probably find pretty decent reams of data on the internet, large amounts of data to convince yourself that this is a fatal condition or something else that's very, very serious. So how do you sift through that? And how do you figure out what the truth is? That's another way that we can help sift through the noise and get to the signal, so that patients who have tried to figure out what's going on because they do feel unlistened to now have a resource that they can trust with experienced people to try to help make sense of what they're finding on the internet and what they're thinking on their own. And it's often the case that in a really busy clinical practice, it just doesn't happen because people don't have time to sit and listen and do that extra research, look up all the records, go to the websites the patient has been looking at, if that's what the patient really wants you to do, and see if there may be a kernel of truth in what they're telling you. They may be absolutely right about what's going on. It's not at all unheard of. It's not that uncommon, actually, for patients to have a really good sense of what's going on. So I think that this professor from decades ago was onto something, and it's even more true now. We need to leverage the information and specialties that we have better. And that reflects back on my story about my grandpa. So he was practicing at a time when there were not many subspecialists. There was much more limited technical information. Technical diagnostic testing was much, much more limited. But he cared about patients and he tried to do the best thing he could for them. So you asked me, how would he feel about practice today? And I said, he would probably be driven nuts by the payer models, but he loved patients and he would want to do the best thing for them that he could. And I think that combining his level of caring and attention to patient quality of care and that personal touch with the benefits of all our technical advancement and our diagnostic testing and our subspecialists now would be to combine the best of both worlds. So in a way, what I'm doing is a retro approach to medicine, where we get back to the prime focus, which has always been in medicine, the patient. At least it should be. And now we have wonderful tools. AI would be another thing we can talk about in the future. But we have, I'm being on a future podcast if you wanted to. But now we have incredible tools. We just need to get back to why are we in this business in the first place? And it's to try to give patients trustworthy care, honest information, and to empower them to make the best decisions they can about their own healthcare and treatment decisions that they have to make too often these days in a vacuum.
Yeah, I was going to ask about AI. We can talk more about it in the future, but really quickly, AI, is it at this point in the game, I don't mean in a year, 2 or 3 years, is it more helpful or harmful? Or I'd say harmful being distracting.
Well, I think it's too broad a question. I don't mean to criticize the question, but
hey,
AI.
that please criticize away.
So AI obviously has a lot of power and potential. And there is no question that in some circumstances, it can augment the accuracy of a human physician in making diagnosis.
Okay, let me change the question.
Sure.
The hype, because the hype right now, the thing I won't debate with anyone is the hype is insane around. Is the hype justified for what AI can do in general right now? Or is it overhyping right now and under delivering? In general, I'm sure there's specific algorithms that are, well, these things are really helpful.
I'll hold you to the right now, because who knows in a week where AI is going to be.
Yes.
It's an incredibly fast moving field, but as of right now, I would say it's overhyped. And unfortunately, that's now going to be a soundbite that people are going to pull out of this podcast.
You can attribute it to me. I even said it to when I interviewed in the first episode the CEO of AI Doc. His company's AI, and I told him on the podcast, I think it's overhyped. I think they're actually a good company. They have some really legit algorithms, but like anything, you remember back when every company was doing population health management, then every vendor out there was doing care coordination, and then it's just every company's doing AI. And I'm like, well, I bet most software companies right now do have some AI in it. And you know what AI is? It's just a better algorithm they're currently using. They're already using algorithms. AI isn't. Everybody thinks like AI, Mark, is like this self-aware brain that's like running the Starship Enterprise or something. And like it's not. It's most of it is just more sophisticated if-then statements. And I'm sure I just painted a target on my back with that. But
So I have a colleague who's a radiologist, and he says, I'll believe AI is ready to make some sorts of diagnoses if it can consistently find the adrenal glands. And it's a poignant statement. And I think that I would make the following
that's
analogy.
awesome.
Remember when GPS was new and it was telling us to exit the highway off the overpass directly down onto the highway below us where there was no off ramp? Remember?
Yeah, like in Office Space where it sent him right into the lake. Yeah.
Yeah. And so that was a all too common occurrence. We would not have relied on GPS blindly at that time. I have a friend who he had a lake home, and it was actually on a small island, and it was in New Hampshire. And one night, this is back in the early days of GPS, one night a boater was at some drinking establishment on the far side of the lake, big lake, and he needed to get home after dark, didn't have adequate lighting, didn't have radar, but he did have the GPS designed to help him drive his car down the highway. So he puts that on the dashboard, gooses the boat, making good time until he hits my friend's island. And in fact, he hit my friend's boat anchored, or not anchored, but tied up at the dock, flies over the boat and lands this boat in the lawn of my friend. Totals the boat, totals both boats. Fortunately, nobody was injured.
That's like one of those farmers insurance commercials.
It was because the GPS was meant for driving. It didn't show small islands.
No, of course not.
So if we rely too heavily on any new technology without knowing what its limitations are and without understanding what it does and how it does it, we're taking a big risk. And I think we're at a high risk right now for over trusting AI. I don't make any predictions about AI. I think it would be foolish to do that. And GPS has come a long way, but I think we're so early in the process of figuring out AI that it is overhyped. I think it has tremendous promise, as I said. And where I really get excited about AI is not the notion of replacing humans to do things that humans do well. It's augmenting human capability. As you know, when I was early in my career in information technology, software research and development, I was trying to use information technology to improve the performance of physicians, accuracy, efficiency in a good sense, meaning reducing wait times for patients, and reducing errors in diagnosis. And that was before AI. I think that if AI tools can do things now, for instance, scouring a 20,000 page EMR chart and helping a physician in real time who's trying to interpret a brain MRI, who doesn't have time to go through 20,000 pages, but would benefit from some of the kernels of information that are buried in that chart, that's a great use for AI. And that's something that it could do, I think, without significant risk of leading us down a primrose path by instead telling us where there's a bleed in the brain that may in fact be beam hardening artifact, for instance. So I've seen misdiagnoses with AI tools for sure. And I think that a risk is relying too heavily on AI to make decisions. I am concerned that new trainees coming out who rely heavily on AI will let their guard down. There is a phenomenon that is well described among residents and attending physicians, where if both are looking at a study, one may believe the other one is taking a more careful look than they are. And if they both do that, neither one's taking as careful a look as they would if they were alone. It's a reliance on your partner that may be unfounded. And if your partner is AI and you have an overhyped belief in its power, and you let your guard down and read too quickly and miss things, that's a way that AI can be misapplied and can cause errors and patient harm. And I am concerned that the overhype may lead to those kinds of situations.
That's really well said. I love the comparison to early days of GPS, and it's a great tool, but you don't just turn off your brain. And the same thing you mentioned, where two radiologists are looking at a study at the same time, and then neither of them is giving the attention that they should be doing it, 100% all in, rather than assuming the other person's going to catch something. And it's the same thing you see with Tesla with its FSD. People turn it on like it's full self-driving, and I'm not going to look at anything anymore. I'm like, you're crazy. And of course, Tesla puts all the warnings on, like, hey, don't just check out and go to sleep. Like, this is great, but still stay aware, right? So you can intervene, but people don't, right? The new normal is, oh, A is going to catch this for me. Oh, the new normal is my GPS is 100% accurate all the time, rather than, and you talked about going off an overpass. I had that. I was out visiting Vital Images in Minneapolis, and it tried sending me off an overpass into the Target parking lot 7 miles away from MSP. And I'm like, you arrived at your destination. I'm like, I'm 7 miles away from that. So it's that same kind of thing where I can't imagine a time anything as important as medical care where a physician just blindly ever trusts what a solution's telling that him or her to do.
I agree. We have felt bad when GPS has misled us and we lose 5 minutes on a trip. But if it's a medical decision, I think the bar has to be much, much higher. And we have to be
totally agree. 100% agree. So last question, anything at this point that, this is, for me, has been amazing. I've loved every second of it. Is there anything we didn't cover that we should cover right now, as opposed to when we talk again later in the year?
I think there's a lot more to talk about, but for me to distill it all down into one or two things, not really. I would just ask that you do stay in touch. I think we should stay in touch. I think it's going to be fun to continue to build this practice. I look forward to having more data for you. And I look forward to making this practice as good as it can be. I'm the first to admit that it's not a perfect practice. I'll also admit it'll never be a perfect practice.
Never,
we're not out trying to solve every problem in healthcare, but what we're trying to do is right here, right now, bring some of the really excellent physicians who are out there, very experienced, very well-trained, to try to take a different tack and try to help patients who are motivated to take more control over their own healthcare and to get real answers that they can trust. And I invite them to join us and to ask us for help. And I also beg a little bit of forgiveness if we're not perfect in doing that, because we are a new practice. So we'll have to have a little bit of sympathy, but I guarantee we will work hard to deliver a trustworthy and a reliable service.
That's fantastic. Like I said, I'm a massive fan of the concept. I would have used it many, many times, and I'm sure I would use it in the future. So again, I'll put a link to your organization in the website or in the description below, and they can check you out. And I'll put other links to like your LinkedIn as well. So anyway, I really appreciate the time, Mark. This was super enjoyable for me. We'll have to do it again.
Absolutely. I very much appreciate the opportunity, Jeremy. Thank you. And at times keep both wheels on the ground.
Nah, not going to happen. I have great intentions. It's never going to happen. You must have talked to my wife before.
You can't complain.
All right, Mark.
Take care, Jeremy. Great talking to you.
You too, sir.
Have a good one. Bye.